And I think we'll get started. So I'm Dr. Madeline Verhofstadt. I'm the Chief of Medicine here at St. Joseph Healthcare Hamilton, and I'm delighted to welcome you all here to our medical grand rounds for this morning. We'll start with a land acknowledgement. We acknowledge that St. Joseph Healthcare Hamilton sits on the traditional territories of the Mississaugas and the Haudenosaunee nations and is within the lands protected by the Dish with One Spoon Wampum Agreement. This is a treaty between the Anishinaabe, Mississaugas, and Haudenosaunee that bound them to share the territory and protect the land. Subsequent Indigenous nations and peoples, Europeans, and all newcomers have been invited into this treaty in the spirit of peace, friendship, and respect. And again, it is my distinct pleasure to be hosting these rounds today and to be welcoming our presenter, Dr. Brad Spellberg. He'll be presenting on the topic of short course antibiotic therapy, and this is a special invited presentation in recognition of IPAC Week. So I'll hand things over to Dr. Zain Chagla, who will give us a more formal introduction to our speaker this morning. Zain?
Thanks, Dr. Verhofstadt. Hi, everyone. Welcome to IPAC Week and this special presentation. I have the pleasure of introducing Dr. Spellberg, who's Chief Medical Officer at LA County University of Southern California Medical Center. He received his BA in molecular biology from UC Berkeley, attended medical school at UCLA, and has had numerous academic honors throughout his training. He completed his residency and subspecialty fellowship at Harbor-UCLA Medical Center. He's got a diverse background, administration, patient care, and teaching activities, NIH-funded research from immunology to vaccinology, and a lot of work on improving care in hospitals and safety net hospitals, and a number of books, even two books that are available through Amazon, The Rising Plague and Broken, Bankrupt, and Dying, which public health crisis in antibiotic-resistant organisms and the U.S. healthcare system. Most recently, though, I think Dr. Spellberg has been actually one of the folks that's really leveraged social media for good, and really has been passionate about short course antibiotic therapy, dispelling myths in terms of, and really trying to dig into the primary literature of some of the myths that I think we carry through our training in terms of how to prescribe antibiotics, duration of antibiotics, the differences between oral and IV antibiotics, and really dispelling some of the stuff, even in guidelines. One of the most recent interventions Dr. Spellberg was involved with, along with a couple of Canadians, was the Wiki guidelines, trying to look at, crowdsourcing and social, a diverse net of people to regenerate guidelines based on pragmatism and newer data. So, really excited for this presentation, and I'll pass it over to Dr. Spellberg to take it away.
Thank you for that very kind introduction and for the invitation, Dr. Chagla, and thank you, Dr. Verhofstadt. It's very nice to meet you. Pleasure to be here today. This will not be a long talk because I think it's uncool to give a long talk on short course therapy. So let's get to it here. When I talk about short course therapy, I always start with why this is important, a reminder. I think people have a tendency to lose sight of, we take for granted, the unbelievable power that antibiotics have to reduce death. These reductions in death here on the right, these are absolute reductions. These are not relative reductions. These are the largest reductions in death you will find from any intervention in medicine. Almost nothing causes a 60% absolute reduction in death. So the one that actually is ironically most shocking to people is the skin infection number. Before antibiotics came along, the death rate from cellulitis was 10%. 10% of people with the simple skin cellulitis died of the infection before antibiotics. That's based on an analysis of 29,000 patients from the pre-antibiotic era. Who would have remembered that? Now, in 1988, the ISIS-2 study was published. This is a multi-center international randomized placebo-controlled trial of streptokinase or aspirin for myocardial infarction. What was the death rate in the placebo arm from MI in 1988? 12%, which means that before antibiotics, cellulitis was as deadly as an MI. And the reduction in death mediated by antibiotics is far greater than the reduction in death mediated by clot-busting drugs for an MI. Nobody remembers that. We just take these drugs for granted. And the problem, of course, is that this incredible power to reduce death is lost the more we use these drugs. This is the ironic trap of these drugs. You use them, you lose them. The incredible reductions in death for individual diseases explain why, at a population level, there was a massive and immediate reduction in death as soon as first sulfa and then penicillin became available. Look at this plummeting population-based death. Deaths declined by 220 per 100,000 over a 15-year period as soon as these drugs became available. And the drop in death was so rapid at the population level that once you had effective antibiotics, virtually nothing else you did mattered. Over the ensuing half century, from 1950 on, so you're talking about the period at which every other major medical intervention was invented: intensive care unit medicine, central venous catheters, pressures, fluid resuscitation, all that stuff barely further budged the reduction in death caused by antibiotics. And what we risk when we overuse these drugs is a regression back up the curve of our population-based death rate. Now, it's been gratifying, intellectually at least, for those of us in the field to see the renewed enthusiasm around stewardship of antibiotics over the last 10 to 15 years. Everybody's talking about stewardship. All you hear about is stewardship, 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 stewardship. You got the WHO, stewardship, stewardship. You got freaking in the United States, Medicare's got stewardship measures, and you got to do it, or you check the box, or when you get surveyed, you won't pay, blah, 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 stewardship. But the reality is, that's not a new conversation. There's nothing new about any of what we're saying. The person who discovered penicillin 80 years ago was warning the public, hey, people are wasting this drug. And he actually said those who do waste this drug in patients who don't need it will be morally responsible for the deaths from penicillin resistance that ensue. So that was like 1945. This is not a new conversation around stewardship. How are we doing nearly 8 decades after Dr. Fleming made this prophetic warning to the public? We're using more antibiotics than ever, and broader spectrum antibiotics than ever, and resistance continues to rise apace. So whatever we've been doing for 7 to 8 decades simply isn't working. That's really the key to understanding the importance of short course therapy. We all want stewardship to work, but very few of us have figured out how to make it work. And it is with that backdrop that when one examines Lou Rice's concept, because it was really Lou Rice in 2008 at a keynote lecture that first publicly called out, wait, what are we doing here, people? It turns out to be really hard to convince doctors not to prescribe antibiotics at all. Doctors are addicted, medically addicted to prescribing these drugs. And to convince them not to give these drugs at all has not been a winning battle for us. And that's one of the major reasons why we've been losing the stewardship fight. But what Lou pointed out was maybe it would be easier to convince them to only prescribe for as long as is necessary to optimize cure. That's an easier selling point. Maybe we'd gain more wins that way. And the reality is, if you treat for a shorter period of time, you're exposing that patient and the environment to fewer antibiotics. And that's what this game is about. Reducing the tonnage of antibiotics put into the environment will reduce the selective pressure driving resistance. And it was Dr. Rice that first suggested this is really a fundamental change in stewardship strategy. Stop telling people not to give it all, because you're not going to win that. Start focusing on only treating for as long as is necessary. And Lou also pointed out If you focus on only on not giving antibiotics to people who don't need them, you will occasionally win and help those people who didn't need them, but you're not doing anything to help the patients who actually did need the antibiotic, the patients that really did have a bacterial infection, but didn't need them for 2, 3, 4 weeks and were getting overtreated. If you instead focus on the duration of therapy, you're going to reduce exposure of antibiotics to patients who never needed the antibiotics in the first place, but you're also going to help the patients who did need antibiotics, but were getting them for an unnecessary period of time. That was the first iteration of what eventually became shorter is better in 2008. The shorter is better movement was branded in this editorial published in 2016, which accompanied a randomized controlled trial I'm going to show you in a couple of minutes. But in the editorial, the question that I sought to ask is, well, what is the evidence around durations of therapy? When y'all choose your antibiotic durations of 7 to 14 days for various infections, what's that based on? What are the data underlying those durations that you've selected? And I traced back in the literature the evidentiary origin of those traditional durations of therapy all the way back in time to 321 AD, when the Roman Emperor Constantine the Great said there will be 7 days in a week. He just issued this decree, there shall be 7 days in a week. That is why you give 7 to 14 days of antibiotics for a typical infection. Had good old Constantine issued a decree saying there will be 4 days in a week, you would be treating for 4 to 8 days, but he didn't. There'd also be only 2 days work days for the weekend, and that would have been really nice. But he didn't do that. He said 7 days. So you give 7 to 14 days of therapy. And so when I'm rounding on medicine or ID, and the resident or fellow asks me, well, how long should we treat this infection for? I will answer, well, how about we give 1 Constantine unit instead of, I call them Constantine units to underscore how ridiculous it is that this is the evidence we use to pick durations of therapy in the year 2022. Now, we don't have to do that anymore because, as I'll show you on the next slide, there's like lots of randomized controlled trials and stuff answering the question of how long to treat infections, but doctors still use Constantine units, and we shouldn't anymore. This has now become mainstream, okay? This is no longer the radical idea it was back in 2008. The largest specialty society in the United States, the American College of Physicians, put out a position statement. Short course therapy is now standard of care for many types of common bacterial infections. This is not like cutting edge radical stuff anymore. It just needs to become integrated into practice by clinicians who get stuck in their ways during training and then rarely, or I shouldn't say that, take a long time subsequently to adapt to new evidence. So now we are aware of 17 distinct disease entities that have been subject to randomized controlled trials comparing shorter versus longer therapy, totaling more than 120 randomized controlled. Like, how many do you need, for goodness sake? More than 120 randomized controlled trials, all of which for these specific disease entities showed shorter was as good as longer. And note that in many cases, shorter was not based on Constantine units. How about that? Maybe everything doesn't have to be based on Constantine units. That's a pretty amazing data set for people to remain skeptical about the efficacy of short course therapy. So let's walk through some of these disease entities. Community-acquired pneumonia was the earliest disease that was subject to this question, shorter versus longer. And we now have 14 randomized. How many do you need? Like, is the threshold like 16? Oh, well, I'm not going to do it at 14. But if you gave me 16 randomized controlled, then like, what is the number? When do you start just, it's like embarrassing and you're just piling on for embarrassment purposes. We have 8,700 patients, people have been randomized in 14 randomized controlled trials, showing that 3 or 5 days of antibiotics is as effective as 10 to 14 days. And this includes in both kids and adults. Now, one of the complaints about some of the earlier studies was that, yeah, that's fine, but it's mostly not very sick patients in these trials. Like the earliest 5 or 6 trials was mostly either outpatient or ward level inpatient. It was, if you look at pneumonia severity index, it was sort of ports 1 to 3 scores instead of 4 and 5. But that changed in 2016 with the randomized controlled trial that I mentioned earlier. The editorial was accompanying, and I'm going to get to that study in the next slide. So we now have data for sicker patients with pneumonia as well. We have for atypical pneumonia even a study of a single dose of very high dose, but 1 dose of azithromycin. And in multiple of these randomized controlled trials, when they sampled the respiratory secretions at end of therapy, there was reduced resistance in patients who got shorter durations of therapy. Kind of duh, right? Because like natural selection and Darwin and stuff, that's how it kind of works. So let's talk briefly about the Uranga study, which was the first CAP study that did include sicker patients. And 40% of the patients enrolled in this study were pneumonia severity indices 4 and 5, the sickest 2 scoring gradients in the severity index. Across all of the analyses they conducted, so you can see it didn't matter what the endpoint was, or is it per protocol or ITT or whatever, p-value greater than 0.05, no difference in efficacy between control and intervention group. Again, more analyses conducted, greater than 0.05, blah, 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 across all of them, except for one. There was one analysis they did that significantly differed between shorter and longer course therapy. Guess which population that was? Yeah, it was the sickest patients. The PSI scores 4 and 5. That 40% that had the sickest, they did significantly differently between shorter and longer. And it turns out they did significantly better with short course therapy. Now, when this was published, people came up to me and said things like, well, that doesn't make any sense. That would mean antibiotics are bad for you. Yeah, that's what it means, because they are. Like, we have this magical thinking about antibiotics that they're just purely good. They're like manna falling from the heaven. They're good when you have a bacteria infecting your body, but they also harm you. And the question really becomes, at what point does the decreasing incremental benefit of each subsequent day of antibiotics start to become outweighed by the increasing incremental harm of each subsequent day? And the data for community-acquired pneumonia from 14 randomized controlled trials suggests that those two curves, decreasing additive benefit and increasing additive harm, cross somewhere between 3 and 5 days. Now, who gets the side effects of the antibiotics? The bacterial resistant superinfections, the fungal superinfections, the C. diff. The sickest patients in the hospital are the most likely to get those. This result from the Uranga study makes perfect sense. Antibiotics cause harm with each subsequent day, and the people most likely to suffer from that harm are the sickest patients in the hospital. This is one of the more recent randomized controlled trials of the 14. I show it because I love this figure specifically, because how many studies do you look at where every analysis done lines up? Look at how every population analyzed seems to favor shorter course therapy. It's like, yeah, these lines cross the zero, so it's not significantly different, but my goodness, it not only doesn't look worse, it really does look more effective, doesn't it? Maybe because we're not harming people with excess unnecessary drug. How badly do we overtreat? Well, I always like to remind people, when Cubist was initially developing daptomycin, they really wanted to put it in the drinking water along with fluoride. They just wanted everybody to just constantly ingest daptomycin. And so they studied it for every disease conceivable, including community-acquired pneumonia, even though, and this is true, they didn't have a single preclinical study that suggested the drug worked. They never did the mouse studies. They just went directly into patients with CAP. And lo and behold, they discovered from these two randomized controlled pivotal trials that the drug didn't work for CAP. And that's when they went back and did the mouse studies and learned, oops, pulmonary surfactant inactivates daptomycin, maybe don't use it for community-acquired pneumonia. The importance of these trials from our perspective, however, is that in order to make the trials feasible to enroll, they allowed a single dose of ceftriaxone pre-randomization, right? So that you were allowed to get one dose of ceftriaxone, so you had one calendar day to do all of the business of enrolling a patient into a randomized controlled trial. And they then went back and looked at the patients in the daptomycin arm. And those patients who did receive a single dose of ceftriaxone pre-randomization had significantly better cure than patients who didn't. One dose of ceftriaxone probably cures 40% of patients with community-acquired pneumonia, and we've been treating historically for 2 Constantine units. That is how badly we have been overtreating this disease. Well, okay, what about VAP? Okay, now VAP, that's a taller bar, right? I mean, these are the sickest patients in the hospital. They have the most resistant pathogens in the hospital, and they have a foreign body in place in that endotracheal tube. But we have 2 randomized controlled trials showing that 1 Constantine unit is as effective as 2 with reduced emergence of resistance at the site of infection, in the respiratory secretions at end of therapy. Now, I like this study. This is one of only 2 non-randomized controlled studies I'm going to show you, because I like this study because it amuses me terribly. I find this study hilariously amusing. This is from the Brigham and the Harvard system, which actually just adds to the amusement in my mind. It's a retrospective study of patients with, quote, suspected VAP. Now, what is suspected VAP? Suspected VAP meant the patient grew bacteria from their airways and a doctor decided to give antibiotics. So they looked at patients meeting that criteria who also had good oxygenation. They were on 40% FiO2 or less and low PEEP. And they asked the question in this cohort, do you need to give more than 3 days of antibiotics to optimize cure? And what they found across all the analyses they did is there was no difference in clinical cure from more than 3 days versus 3 or less days of therapy for suspected VAP who were oxygenating well. And the very amusing conclusion these authors drew, which somehow made it through 3 peer reviewers and an editor, was that if you have patients with suspected VAP who are oxygenating normally, you can treat for 3 or fewer days of antibiotics. My conclusion from this study is that if you don't have VAP, you don't need more than 3 days of antibiotics because these patients didn't have VAP. They had bacteria in their airways, duh, because the airway isn't sterile, and they were oxygenating normally, so they didn't have no VAP. So this goes back to the point Lou Rice made. If you're going to give antibiotics to people who do not have infections, at least do us the courtesy of doing that for a brief period of time. And that is still a win because that patient is still better off getting 3 days of therapy for their non-infection than 14 days of therapy for their non-infection. Pyelonephritis and complicated UTI. We have 9 randomized controlled trials. That seems like a lot. 1,800 patients have been randomized. 5 to 7 days is as effective as 10 to 14 days. Now, most of the original studies were exclusively in women, but we now have 1 study that was half male and 1 study that was exclusively done in men in the VA population in the US. And we now have data for Bactrim too, not just the fluoroquinolones. And in all of these studies, short course was as effective as longer course. Now, people say to me, but my patient's diabetic, so I need 2 Constantine units. And my response is 40% of the patients in these randomized controlled trials were diabetic. You don't need 2 Constantine units, even if diabetic. But my patient's bacteremic, so I need 2 Constantine units. So we're 10% of the patients in these randomized controlled trials. You don't need 2 Constantine units of therapy for pyelo, even in diabetics and even in patients who are bacteremic. 5 to 7 days is adequate. Complicated intra-abdominal infections. We have 2 randomized controlled trials, 4 days post-source control is as effective as 10. At this point, people will stand up when I'm doing a live talk, start throwing objects at me and saying things like, what are you, crazy? My patient has 14 independent abscesses in their abdomen, and you think I could just give 4 days of antibiotics? That's not what I said. I said 4 days post-source control. In these trials, source control was obtained, and after source control was obtained, they gave 4 additional or 10 additional days. You don't need more than 4 days from the time of source control. So people say, well, what the heck does source control mean? And my response, which I did post, Dr. Chagla, on Twitter the other day, is source control is like pornography. It's hard to define, but one knows it when one sees it. When you've decided source control is obtained, 4 days after that is adequate. Now, we've talked about VAP and pylo and intra-abdominal infections, and those are the 3 principal sites of initial infection that lead to gram-negative bacteremia. In addition to those many randomized controlled trials, which did have bacteremic patients in them, there are 3 separate other randomized controlled trials that evaluated patients with gram-negative bacteremia irrespective of site of the initial infection. More than 1,300 patients randomized to 1 versus 2 Constantine units. This did include patients with cancer or organ transplantation and many different types of gram-negatives, including the Enterobacteriales and including non-fermenters. And 1 Constantine unit was as effective as 2. Now, you could then ask the question, all right, well, that's great. You've convinced me. We have an incredibly robust data set. You don't need more than 1 Constantine unit for gram-negative bacteremia. Do you need a Constantine unit? Will 5 days work? Will 4 days work? And I would say the same thing for VAP. I don't know, because no one's done that trial. If somebody did a 5 versus 7 day study, I would not at all be surprised if 5 days was adequate for gram-negative bacteremia or VAP, but that study hasn't been done yet. What we know is you don't need more than 7 days. We don't yet know if you can go shorter than 7, but it won't surprise me if in the future those trials are done, and we can. Here is the point at which, in a live talk, the ID specialists in the audience stand up and start throwing rotten vegetables and fruit at me, because I'm going to tell you that you don't need more than 3 to 5 days of antibiotics for acute exacerbation of chronic bronchitis or COPD, or also bacterial sinusitis, or sinusitis, period. And they will say to me, well, of course not. You don't need any antibiotics for these infections because they're caused by viruses. So why would you need more than 5 days? And again, I'm going to reiterate Dr. Rice's original point. If you're going to give antibiotics to patients who don't need them, at least do us the courtesy of doing it for a brief period of time. That is an easier argument to win, and you will be successful at winning that argument, as opposed to not giving antibiotics at all. Now, acute bacterial skin and skin structure infections, that this disease is an FDA construct that includes 3 disease entities: cellulitis, major abscesses, which means 2.5 centimeters in diameter and or signs of systemic infection, and wound infections, all combined in these pivotal trials, in these randomized controlled trials. And 3 trials have shown convincingly that 1 Constantine unit is as effective as 10 to 14 days. There is this one other study, which is extremely annoying. This is a highly annoying study because A, they intended to enroll more than 300 patients and they enrolled less than 150, and it took them 6 years to get there, which is very strange, by the way, because ABSSSI studies typically enroll very quickly. But for whatever reason, these folks could not complete enrollment in their study, so they stopped at less than half the planned number of patients. They also excluded 80% of the screen patients, which again, like what? Who were you screening that you couldn't get cellulitis into a randomized control trial? There was an imbalance in the arms in that more patients in the short course therapy arm were obese and more had recurrent cellulitis. And the cure rate was very low. 50% success rates for cellulitis. Historically, that number is in the 80 to 90% success rate, which makes you wonder, were they actually enrolling cellulitis? Were these recurrent cellulitides actually venous stasis or other mimickers? So it's hard to understand what exactly happened in this study. In this study, the primary efficacy analysis of this very flawed study still showed no difference between a short and long course therapy, but as a secondary analysis, there was a higher relapse rate in patients who got the shorter course regimen. And people, oh, this shows that it doesn't work. And I'm like, okay, so this highly flawed, imbalanced study that didn't complete enrollment and had weird low cure rates as a secondary outcome trumps the 3 other well-conducted randomized controlled trials in which there was no difference? I don't think so. This is a weird outlier study. It is important to acknowledge it, but I will again reiterate, even in their primary analysis, there was no difference in outcome. It was a secondary analysis of a weird study that is contrary to the other 3 high-quality studies. For chronic osteomyelitis, we have numerous studies, but the real principal point is this. In the 2 primary studies, including a very large study of vertebral osteo, 6 weeks was as effective as 12 weeks. We know you don't need to give more than 6 weeks of therapy. This thing about just continuing forever, because you keep getting MRIs and the MRI keeps getting read as residual marrow edema, could be bone remodeling or residual infection. You don't need to do that anymore. 6 weeks is adequate therapy for a straight up osteo. The question is, can you go shorter than 6 weeks? And the answer is we don't yet know. There are small randomized controlled trials. These are like 30, 40 patients each, suggesting that in some cases, maybe you can go shorter. And I know that in Europe, they often use 4-week standards. So this isn't terribly surprising. In the future, I hope we get a larger study of 3 or 4 weeks. And I suspect it will be possible to go shorter than 6. For now, 4 weeks in Europe, 6 weeks in the US is fairly standard. And we have good randomized controlled trial data showing you don't need longer than 6 weeks. And then for Dr. Verhofstadt's special as a hematologist, there is hematology. Now, I am getting to be of advanced age. The dementia is following that age. So I'm starting to lose the younger members of the audience with this analogy, but I'm hoping that the folks watching still are aware of who this character is from the show Seinfeld, right? So this is Newman. And every time Jerry sees Newman, he goes, Newman, because Newman's like his nemesis and stuff, right? And so like when I'm on ID consults, it's for me a heme consult. It's like I get the heme consult and I'm like, heme. Now it's not that I don't like the hematologists as people. Like I love our hematologists. I love these people. They're wonderful human beings. But like, does every patient need to be on 16 antibiotics for 10 years? Because that's what it's like, you know, frustrating as an, like, you know, these are like the antithesis of stewardship type patients. So imagine the glee. Joy doesn't cover it. It's beyond joy. There's like a giddiness to it. It's truly glee. The glee that occurred in my diseased brain when this study was published in a hematology journal, the Lancet Hematology. And you could just imagine the joy and satisfaction I take in citing this study when I do hematology consults. This was of high-risk neutropenic fever, multi-center study from Spain. The highest risk neutropenic fever that there is, these patients all had liquid cancers or stem cell transplants, okay? And they were randomized to the traditional duration of therapy, which of course is continue antibiotics until afebrile and non-neutropenic versus shorter course therapy, which was until afebrile for 72 hours and clinically stable, irrespective of neutrophil recovery or not. The patients who were the short course arm got fewer antibiotics. That's pretty expected. And there was no significant difference in death, although I will point out numerically the death rate was lower in the short course therapy arm. That's short course, that's standard course. And you know what there was a significant difference in? Serious adverse events, which were significantly lower in the short course therapy arm, including due to superinfection, C. diff, fungal infections, right? Again, go back to who gets the side effects from antibiotics and the resistant bacterial infections and the fungal infections and the C. diff? It's the sickest patients in the hospital. These are dangerous drugs, and more is not better. It's actually even more important that more is not better in the sicker patients. We now have a real world study. This is the second and final non-randomized study I'm going to cite, a real world experience of applying the how long criteria to nearly 1,000 patients. 446 got short course, 512 got the historical duration regimen. Interestingly, in this real world experience, nearly half the patients were bacteremic in the short course arm. This wasn't just empiric neutropenic fever. They actually applied these criteria to patients who were infected in the bloodstream, and it still worked. Patients who got the how long criteria had fewer antibiotics used and lower mortality, statistically significantly lower mortality than in the longer arm. This study just came out last week. It's a second neutropenic fever study designed a little differently. This was, you got a total of a minimum of 3 days of therapy, and you had to be afebrile for 5 days, or you were continued until neutrophil recovery. So this is slightly different criteria, but the same general concept. And once again, there was no difference in treatment success or mortality in the short course arm. Does this always work? People will say to me, well, what about TB? Because like we still treat TB for a really long period of time. Obviously, TB is an exception, right? Well, we could argue that. We now know you can treat latent TB for between 1 and 2 or 3 months, as opposed to the 12 months historically. So we have been moving shorter based on randomized controlled trials for latent TB. Yeah, but we still treat pulmonary TB for 6 months. Okay, true, but originally it was 18 months. So even you can make the argument that as new trials have come out, we have been moving shorter for even active TB. There are suggestions, early suggestions, we may be able to get that down to 4 months. And as new drugs become available in the future, that might actually get lower. We have to keep an eye on the randomized controlled trials. There are, however, clear exceptions. There are a couple. The DTPO study published last year of prosthetic joint infections convincingly demonstrated, I think, to most people that 12 weeks was superior to 6 weeks. Now, I will point out in the DTPO study, the imbalance of success was almost entirely driven by the retention of device cohort. So in patients who had exchange of the prosthetic, there was not a significant difference. The significant difference was driven by the cohort of patients who just had their device debrided, but was retained. There is another exception in children with otitis media under the age of 2 years. There is a large randomized controlled trial from some years ago showing 10 days resulted in superior clinical cure to 5 days. But I will point out there has been a meta-analysis of numerous other trials in children over the age of 2 that showed that short course did work as well as long course. So I'm going to carve out otitis media in an under 2-year-old. I don't know why that is. I don't know if that's a drug dosing problem, but I do believe it based on standard dosing. For a less than 2-year-old, you need 10 days of therapy. Now, what about strep throat? Because I did a Medscape piece on short course therapy some years ago, and it got more comments than any other Medscape article they had over the last decade. And they almost all the comments said I was a moron. And they were almost all written by pediatricians. Now, I don't know, like I thought pediatricians were like the nice people. I don't know if it's the bow ties or what. Something was happening. Something was off with the pediatricians. They were furious at me over strep throat. And I was like, but I didn't mention strep throat. Like we didn't talk, like, why are you angry about strep throat? So that caused me to go back, that very traumatic experience being yelled at by pediatricians. That's pretty traumatic. Like getting yelled at by a surgeon, you expect. Getting yelled at by a pediatrician is kind of a shocking experience. So I went back and looked at the literature for strep throat. And it is true, if you dose penicillin traditionally TID, there are controlled trials showing higher cure rates, symptom resolution with 10 days of therapy. Not lower rates of rheumatic fever, because the rates are so low, you'd need a study of 10,000 people to evaluate that. So that's never been shown. But symptom resolution, 10 days more effective than 5. However, pediatricians, okay, don't yell at me, because there are randomized controlled trials of oral cephalosporins showing 5 days is as effective as 10. And there is now a really cool study of 4 times daily penicillin, in which they said penicillin is a time above MIC killer, and it's got a very short half-life. Maybe if we dose it more frequently to keep the level of penicillin higher above the MIC for longer, that'll work better, and it did. 4 times daily penicillin, 5 days was as effective as 10 days. So yeah, it's not quite as clear as the bow tie angry pediatricians wanted to make it. There's some mixed literature depending on how you treat. Final concept will be done within the next 3 minutes. Who amongst us has told this to our patients? Well, who amongst us hasn't? Hasn't everyone said this? Isn't this the universally held belief? If you want to prevent resistance, take every last dose of antibiotic I prescribe you, even after you feel better. What's that based on? It's based on nothing. It's a myth. It's an urban legend that is based on no data. And it was actually Dr. Rice in 2008 that pointed this out. This is not based on any data at all, or even rational science, right? As he said, it may be good advice if you want people to take a complete course, but it's poor advice for preventing resistance. The longer you take the antibiotic, the higher the rate of emergence of resistance will be. It's like natural selection and Darwin and stuff. Where is this myth derived from? Dr. Rice traced it back in literature in his talk to a case series published in 1945 of CAP treated with penicillin, in which the authors said they treated until patients were better and then gave 2 or 3 more days after that to prevent relapse. The problem is they weren't preventing relapses, they were preventing reinfections. It's hard for us to imagine or remember the pre-vaccine era. Back then, everybody was colonized with pneumococcus. If you just swabbed random people on the street, half the population was carrying pneumococcus. Because of the vaccines, very few people carried pneumococcus. But back then, people got reinfected. Now, how do we know these were infections from a different pneumococcus? Because they serotyped them. And the relapses were a different serotype than the original infection. These were not relapses. These were new infections. Giving penicillin for 2 to 3 more days was not making any difference whatsoever. So this is a myth that derived from a misunderstanding of an uncontrolled case series published in 1945. And we need to stop telling people to do this. Don't tell people to keep taking antibiotics even after they feel completely normal and their symptoms are gone. More importantly, if you give 14 days of therapy for a cellulitis or a pyelo, yeah, you're going to have a week of therapy left after your symptoms are gone. But if you give 5 or 6 days of therapy, you're not. They're going to be finishing their antibiotics just as their symptoms resolve. So this entire conundrum goes away if we just use evidence-based short course therapies based on randomized controlled trials. So to conclude, so for the 2/3 of the audience I put into coma, it is now time to emerge from said coma. This really is all you need to remember from this agonizing experience that you've spent with me this morning. We really do need to save antibiotics. We have to do much better than we've been doing. We have numerous randomized controlled trials that show that short course therapy works for many diseases. And if all you take away from this horrifying experience that will require several years of therapy to overcome, shorter is better. And with that, I'll stop and take any questions. Thank you very much.
Thank you very much, Dr. Spellberg. Huge virtual round of applause from a very big audience here who's joined us today to take in your very valuable perspectives. And to one question that's just popped up on the chat, I'm sure many people are wondering the same thing. The recording for this talk will be posted within the next couple of days on the McMaster Department of Medicine YouTube channel. So for anyone who's attending today who wants to pick up any kernels that they may have missed while listening to the presentation or sharing the link with friends and colleagues. So thank you so much. And we have Dr. Zain Chagla as well here with us, helping to co-facilitate the Q&A. There are 3 questions in the Q&A. Zain, did you want to start things off?
Sure. So I think the first one that's in the Q&A is very relevant, and I know you've been incredibly vocal about this. What about the mechanisms of antibiotics in terms of bactericidal versus bacteriostatic?
Yeah, so I have a whole nother, if you ever want to be tortured in a different venue, got a whole nother talk on that topic. The proper response to this debate is to identify, using functional MRI, the neuron in your cerebrum that is storing the memory of the word static and cidal, and then selectively delete that neuron. That is the proper response. This is a nonsense concept. Every single antibiotic on the market today kills bacteria. This idea that there are drugs out there that inhibit growth but don't kill is total nonsense. The only difference between a cidal and a static antibiotic is that a cidal antibiotic has an MBC that's more than 4-fold above its MIC. And it's this crazy in vitro construct that has nothing to do with patient care. And in a systematic review of 56, I think, randomized controlled trials, 49 showed no difference in clinical efficacy in patients between a static or a cidal antibiotic. 7 trials showed static agents were more effective, and 1 trial showed a cidal agent was more effective. So we need to put this concept to rest. There is no difference in clinical efficacy whether the drug is static or cidal. Say bye-bye to that concept.
Very definitive. The next question comes from, I presume, one of our nephrology colleagues. Can you comment on dialysis end-stage renal disease populations? Is shorter better in this patient population?
I can't comment specifically because I don't have randomized control. I mean, I guess it depends on the type of infection. If you've got a cellulitis patient, shorter is right. I wouldn't be worried about that. But I guess it would depend on the nature of the infection. If you have an end-stage renal failure patient in the ICU with a VAP, shorters is good. So I guess it's not so much the population, it's the disease entity that you're treating. If it's like an infected fistula, I have no randomized controlled trials to answer that question.
Right, fair enough. While we wait for more questions, I have one that's kind of burning, I guess, in that concept. So, you work in the United States, and I think one of the issues that trainees and young attendees face is, medical legal consequences of being wrong, or medical legal consequences of, adverse outcomes in patients, and again, what that means for them. The need to prescribe often is in that, well, I don't want to miss X, I don't want that patient to get sicker, I don't want the consequences of that patient to get sicker. I guess, from your context and working in a US center, how do you navigate that more than just the data that's out there?
Yeah, that's a great question. So there's the conceptual and then there's the practical. The conceptual is that it's tragic that we only focus on the harm that could occur if we miss something and don't focus on the harm that does occur when we overtreat. So you think you're not likely to get sued when you cause the C. diff in the patient for giving 14 days of therapy instead of 3 or 4 days? We always remember the harm that is caused by omission, and we tend to forget the harm that is caused by commission. So with that as a conceptual background, the answer, I think, for me is A, this is why we have put expected practices into place in our facility that are signed off on by the medical staff, so that this is the collective medical experts in the hospital saying, we expect our colleagues to practice this way. And that gives you the cover. Well, I gave short course therapy because that's what the medical staff here expects us to do. It puts the onus of the decision on the institution, the organization, and helps alleviate the sense of onus on the individual. Further, this is why we need guidelines to join the 21st century, because where you really run into trouble is when idiot specialty societies put ridiculous guidelines out that are contrary to science. You practice based on randomized controlled trials, and a lawyer sues you because the guidelines say you did something wrong. So this is why I've been pushing very hard that guidelines are out of touch and out of date and need to be reformed.
Yeah, I think that's very reasonable. The wiki guidelines, I think, are a nice stab at that in that sense. And again, you know, even as the VAP guidelines, et cetera, you're right. They're a bit out of date. They're use combination therapy. They're very, very medical legally based, and so you know it does make it difficult for someone in the midst of practice to then you know try to use newer data to deal with things. Although you're right, you know, it may be a matter of time before that C. diff patient sues the hospital to say, well, you have a RCT saying 5 days is better than 14. Why did they get 14 in that sense? So it might be the right opposite. Madeline, Dr. Verhofstadt, I think you have a couple of questions. I got cut off just in the middle of it, so I may have lost them in that sense.
Yeah, so we've got a few more questions that have come up here in the Q&A. I'll take two, and then if, as time allows, Dr. Chagla will read out the second two. So number one, what do you think about individualizing antibiotic durations to patients' clinical resolution of infection? For example, decrease in inflammatory markers, resolution of fever, and how best do you think we can study this? You spoke to that a bit toward the end of the talk.
Yeah, it's a great question. I would like us to move in that direction. It turns out to be difficult to operationalize. But I do think when patient symptoms are resolved, that's when I stop. I don't continue past resolution of symptoms. We asked Emily McDonald and Todd Lee to write something about this. And then there was another group from Stanford that put out an article in Clinical Microbiology Infection recently asking these questions. And they did the best they could, and they put some thoughtful answers out there. So this is going to be the subject, I hope, of future study. I do hope eventually we can move to individualized durations of therapy. Based on biomarkers, we need data. Like we need trials to show biomarkers that predict success or failure better than any biomarkers we have right now. I think procalcitonin is the one that comes closest. I'm pretty convinced that if your procalcitonin resolves, it's safe to stop therapy. But I do know that if your symptoms are gone, you don't need to continue on antibiotics.
Okay, great. Thank you. Next up, is there evidence that EMR nudging, i.e. suggesting maximum duration of antibiotics when they are first ordered, is effective?
That's a great question. There is, as you probably know, a lot of evidence that EMR nudging is effective in other contexts, including for not giving antibiotics at all. One would therefore suspect that EMR nudging would be effective for duration of therapy, but I haven't seen a specific study asking that specific question.
Excellent, thank you.
So I'll move on to the next questions in the chat. How do you reconcile when physicians say this population didn't fit into the RCT or was excluded, we must use longer course? And I think you showed some data for transplant, which is great. You know, we're still working as part of the large consortium in Australia, for example, to do the balance trial, including at our center. But you know, there are patient populations that will be excluded in balance, and so how do you reconcile that when we come out of the other end of this RCT?
That's a great question. I'm going to give you two seemingly contradictory answers, but I actually don't, in my mind, they're not contradictory. So first point is this. People will say to me, well, my patient is not doing well. Why would I stop at day 3 when they're still super sick? What we're talking about here is changing the median duration. We're talking about the typical sort of routine patients that you care for. Doctors must always have the ability to deviate from practice that is based on a randomized controlled trial for the reasons you're alluding to. If your patient's not doing well, obviously you're not going to give short course therapy. You might want to also think about, do you have the right diagnosis? But the point is, yes, you should always be able to override. You just type into the medical record, I'm using longer because this patient doesn't fit the standard short course regimen because of X, Y, or Z. So what we're trying to do is shift the standard, the median, but we're not talking about the outliers. You always have the ability to override for outliers. The flip side is, I'm not sure that immune status is a good reason to say, oh, they wouldn't have been enrolled. Antibiotics are really good at killing bacteria. You're going to drop the burden of organism, and there's actually published studies on this, by 3 logs per day. And most infections are not more than 6 to 7 logs of bacteria. So within 3 or 4 days, even in patients who are fairly immunocompromised, you're going to really start sterilizing the infection unless there is if there is a source control problem, a big abscess, the antibiotics don't work as well. What I think is more important than the immune status is clinical failure. Like the patient is not clinically responding well. All of these short course studies are based on the patient was doing well at the time the decision to keep going or not was randomized. If you're not doing well at the end of your short course regimen, obviously short course regimen doesn't apply to you.
Very reasonable. Yeah, and I think again, we're going to have excluded populations. It is that clinical context that's really the big part of this in that sense. I think this one might be the last question just because of the time. So Dr. Pine, given the concerns of how we label pneumonia isn't bacterial pneumonia, similar to the study on VAP, and if they never condition 0 days and will be and if they never had the condition, 0 days will always be non-inferior if it's viral in that sense. Are the results of shorter therapy being non-inferior consistent with the infections which they're strictly defined? And I think this is actually a really interesting question in COVID. A colleague of mine in the US reached out and said, a third of their pneumonias are now COVID. And so if you were to do a pragmatic RCT for antibiotics without necessarily excluding viral very well, you're going to get a 0 result in all those patients that had viral pneumonia where 1 day, 3 days, 5 days, 10 days, 20 days are going to act exactly the same. So, how do we reconcile these non-specific disease entities in terms of shorter is better?
Yeah. So modern studies of CAP pre-COVID, like from 2017, 18, 19, using sophisticated molecular methods showed that 2/3 of CAP is now viral. It's like, it turns out vaccines work. Who'd have thunk it, right? There just isn't much pneumococcal carriage or H flu carriage anymore because so many people are vaccinated. So yes, that is true. That makes it a lot easier to be non-inferior when you're short course. That somehow negates the benefit. You're giving all these people who didn't have bacterial pneumonia 14 days of therapy. It's still a win to give them shorter. Now, your question is, well, what if they really do have bacterial? In the randomized controlled trials from the early 2000s, which we do have for community-acquired pneumonia, there were much higher rates of bacterial confirmation. And in those studies, 5 days worked just fine. So again, remember, effective antimicrobials will reduce your bacterial burden 1,000-fold a day. They're extremely effective at killing these bugs. And if you've got a bacterial burden that is typical, within a couple of days, you will have sterilized the infection. And most of the symptoms that remain are the inflammatory response to the infection that just needs a few extra days to your body to just resolve the inflammation without there being residual bacteria at the site of infection.
All right. Well, thank you for this enlightening talk. I think all of us have had, shorter is better in the background, and certainly I think, in coordinating with IPAC week, the burden of antimicrobials and the downstream effects that they're leading to for AROs, for C. diff, and for many other complications is top of mind. Again, I really want to thank you for coming out. I think obviously it's 6 in the morning in California right now. And so, doing a talk out east is great for us early in the morning, but I know even earlier for folks out west. And again, to everyone on the call, we will be posting this on the DOM feed. So, for anyone who missed it, and I think it's a great talk that most of our trainees should probably take a look at, feel free to share the link as it comes. Madeline, anything else?
Everybody.
Dr. Verhofstadt, anything else?
Yeah, no, echo those huge thanks, Dr. Spellberg, and thank you to Dr. Chagla for arranging for you to join us this morning. I'm sure I speak for all of the folks who've joined today. A lot of excellent food for thought, and I personally am going to try not to let my ego be too wounded by the comparison to Newman from Seinfeld.
He was the best character.
For sure. For
Love
sure.
to hate, right? And just for everybody else, we'll meet back for medical grand rounds next Thursday morning. We have Dr. Keith Choi from gastroenterology presenting. And thanks to all for joining. Have a fabulous day and a wonderful week.
Take care.
Take care.
Everybody.